COVID-19 cases are on the increase in various parts of the world as the Omicron and Delta variants reign supreme. In the past few days, Nigeria has recorded a 500% surge. Yes, you got that. 500% surge in case incidents, while South Africa has recorded a sharp decline in its number of cases in the past 5 days, to make an interesting contrast. Now, COVID-19 continues to be a topic attracting the attention of the world, with Africa not left out. The fourth wave of the pandemic is in full swing amid endless discussions about the importance of vaccines and how much they impact the world, and especially Africa. Welcome to VSA. I'm Sulaiman. Well, it's been almost 2 years since COVID-19 first ravaged the world and sent economies on their knees, struggling to stay afloat. Many countries are yet to recover from the shocks of the pandemic and what it means to survive. Africa, which has recorded more than 9 million cases, over 225,000 deaths, is considered the least affected part of the world. With just above 2.5% of the cases recorded leading to death, Africa and its relative ease has been a subject of public health discourse and research. In spite of the continent's lower numbers, the continent is still a focal point of the world, with South Africa suffering heavy Delta and Omicron variants-driven infections in recent months. The fourth wave, powered by Omicron and Delta variants, have become a new challenge to the world, and it's high time African countries applied caution. Joining me to look at this from South Africa is Professor Shabir Moosa. He's the Executive Coordinator, African Forum for Primary Healthcare, and from Kenya, Dr. Victor Ngani, Head of Clinical Services, RFH Healthcare, Nairobi, and from Lagos, Nigeria, Dr. Akase, who's the Head COVID-19 response team at the Lagos University Teaching Hospital. Gentlemen, good to see you all, and thanks for what you're doing for the continent. Very quickly, let's start with you, Professor Moosa. When we talk about the fourth wave, tell us what you know about the fourth wave and how has Omicron impacted it?
Well, it's great to be here, and thank you for inviting me. I think Omicron has certainly been a big scare. Largely because of the genomics that was done on it when they found it, to see that there were 30 mutations as opposed to the 3 from Delta, which was the previous dominant virus. And I think that created the kind of scare all over the world, which led to this very knee-jerk response of banning travel from South Africa. Obviously, in South Africa, we've been very nervous about it. Especially with the rate of increase in positive cases. If anyone looks at the graph, you will see that it's escalating very, very quickly. We've been relieved that whilst it has grown quite substantially and is possibly peaking in South Africa, mostly in the Gauteng province, that the sort of rates by which severe illness is being shown up is less than was with the previous wave. So that's the sort of initial evidence. I think it will have to wait until the end of December to see that, because of the lag of 2 weeks from the time people are tested to the time that they might land up in a hospital. So at the moment, it seems to be reassuring. That, I think, is good news for the rest of the world and Africa, hopefully. That some of these things that might protect us are protecting Africans in the main. But I think nonetheless, the numbers are still grown. If you look at the hospitalization, that has grown, not as exponentially as in July. And in fact, the positive numbers have exceeded July, but the hospitalizations have not. So I think these are just, beginnings of what we might see as the fourth wave, alarming, but then again, somewhat reassuring. I'm not sure whether you want me to spend any more time on talking more about it. I think that you can interrupt me at any point. I can wind on for you.
All right, okay, Professor Moosa, certainly I'll come back to you. Let's quickly go to Nairobi, Kenya, where Dr. Ngana is. Dr. Ngana, you've been with us here on this program, a couple of times, and we've talked about this. And here we are again, talking about a fourth wave. You had warned, I recall then, that Africa shouldn't drop the ball. Are you surprised that this is happening, especially from looking at the news coming from South Africa and Nigeria?
Not at all, Sulaiman. I think we've been issuing this warning for the longest time now. I think the only thing that surprised me was how long it took for this wave to start. If you remember the last wave just a couple of months ago in Kenya, around that time, it seemed as if there was this fatigue around the discussions with COVID. People didn't want to be in lockdown anymore. They wanted businesses reopened. And at some point, I sort of felt the government giving to pressure towards the tail end of that wave. And we were a little bit concerned that the wave may be extended. It wasn't extended. And I think for the last 2 months, we sort of had numbers going down as 2.5% positivity rates. But then suddenly, over the last 2 weeks, we have been seeing a sudden surge in numbers in Kenya as well. And those numbers have gone up almost sixfold. And we are now seeing positivity rates of excess of 25% day after day. Today it was a 27% positivity rate. The day before yesterday it was 9%. And I'm not surprised at all. We in Kenya, the last few weeks have been marked with this feeling that COVID has been vanquished, erroneously they must say. And as a result of that, people had gone back to almost normal. There are still a few of us who are wearing masks, but many people were going about life the same way that we were before COVID happened. And therefore, there's no surprise at all that we're in the middle of another wave.
Well, Dr. Akase, help us here. You're the one in Lagos, and Lagos is the epicenter of the virus, and a whole lot of things happen. And also recall, we had this conversation, and almost true to prediction, a bad prediction. We were worried, talking about the Yuletide. It is upon us, 500% increase. That is mind-boggling. How are you handling this?
Thank you very much, Sulaiman. It's good to be here again. So to be honest, these numbers reported is truly a market underestimation of what's really on ground. Like my colleague from South Africa said, thankfully, we're not seeing such severe cases in terms of the number of people coming for admission is not consistent with the number of positives we're seeing. But two things are clear. One is the fact that because the communication has been that Omicron is essentially mild, even people who have had exposures and who are having symptoms, from a large number of which were saying, well, I'm not going to go test. I'm just going to take whatever and treat symptomatically. So we have a large number of people who feel that this is not a big problem. They are not coming for testing. So those numbers are not a true reflection, of what's going on. But the second major issue is that, yes, in terms of the proportion of people who are sick enough to come for admission, it's not there. But what we're seeing now is that because of the sheer numbers involved, the pressure for admissions is now picking up. I've been in touch with colleagues elsewhere in the other treatment facilities, and what we're seeing is the pressure in the number of people who are requiring admissions. Now, this fall into two categories. You have those who are coming for admission because their COVID is severe. Those are not that much, to be honest. You have a few of those. However, we have people who come for care. So, for example, pregnant women who come to deliver and they develop signs of COVID and a fever, and some hospitals say, we're not equipped to do this. So those categories of people are now having to be referred to a few centers, and as understandably, that's putting up some pressure, in terms of the few centers that can handle things like COVID and pregnancy, COVID requiring emergency surgery, those kind of things. So, where that kind of demographic, because of the sheer numbers of people testing positive, again, that's mounting pressure on a few places. But thankfully, in terms of proportion, it's still mild, to a large extent, yeah.
Let me bring in Professor Moosa again, and it has to do with your area also of, medicine, primary health care. A lot of people talking, in Nigeria and other parts of Africa about vaccine hesitancy. Till this moment, we're seeing less, people still believing in vaccination, especially as it relates to COVID-19. Let us in on what you and your team are doing in terms of sensitization and how far it is going in the fight against COVID-19.
I think in all governments and particularly in primary care, primary health care, South Africa being an example, I think they are battling the misinformation, epidemic, pandemic itself. I think WhatsApp has just become just an enormous way of just spreading information, and it's so easy to educate people about validating before they decide to believe it. And I think that's going to be an enormously difficult challenge going forward. But apart from the information campaigns that governments are doing, I think it's just to step that up, to reach out with, I think, stronger community-oriented systems of healthcare. I think the big challenge has been that health systems function as facilities. They need to actually bring on community health workers to be part of the equation, linking the patient or the people in the community to that facility. And that's something as Afro-PHC we strongly advocate. And I think that is, the process. I think if I may add to that, some of my other concerns, and I think just based on the conversation so far, I think, yes, we're fortunate that the Omicron virus morbidity, mortality is not as severe. But I think it does demonstrate the challenge that our response tends to be overkill in many instances. There are a lot more other diseases that are very much more greater morbidity, greater mortality, but the community response, the government response, seems to be driven not by what is going on within the country, but by an international discourse. And I think, yes, we're fortunate Africa is not affected very much. And I think we want to keep it that way. But there's an attitude that I think doesn't warrant, and we at primary care see that across the continent, where lockdowns have actually really damaged primary health care enormously. We understand the need to respond to the COVID crisis, but the COVID crisis is not the only crisis in Africa in health. And I think we need to have a bigger picture. And I'm glad that in South Africa, for example, and I really hope that the rest of Africa, hears this, that there has been a very measured approach to any lockdown. So we've in fact stayed on the same lockdown as prior to the COVID rise. And yes, it's kind of frightening when you see people gathering on beaches and crowds. And it's something that maybe is because of the way in which it's panning out. But I think that's exactly what governments need to look at, is their data locally, and not come like a sledgehammer on an ant because some foreign government thinks that that's the way to do things, and we don't know better. And I think we should believe in ourselves and the data that we can collect on the ground and respond to what goes on the ground. And I think that my view is that we should not crush our health systems, just in the fear. And I think that what has been mentioned in Lagos about a few hospitals, for example, only dealing with the condition is in fact itself a fallacy. This is 2 years dated. We in fact should be treating COVID in some ways as no more than the influenza. TB is more dangerous. Yet we don't have the same kind of attitudes where people say, no, I won't take it in. I will not take a TB case in. Why? And I think that there's enough knowledge on the ground to know that you can manage it symptomatically, but when you reach a point where it is actually serious, then you refer to an appropriate hospital. I think that in our setting, as an example, in South Africa, they've said there's no need, and this has come out by the Medical Advisory Committee of the country, which says no more need to contract trace, no more need, to in fact be isolating, because this virus is moving in such a fluid manner that's all dated. And I go to a gym where even today in South Africa, they're checking my temperature, which is completely useless.
Well, I think that's a big point, and I'm quite sure your colleagues in Lagos and Nairobi will weigh in on this. I'll come to you, Dr. Akase. Let me quickly go to Dr. Ngani, because some of the key things Professor Moosa has raised are some of those things some medical experts raised in Nigeria not too long, talking about malaria, saying that more people have died of malaria. And as he's highlighted, it would seem as if the governments across the continent have ignored other parts of our health sector, to the extent that all eyes are on COVID-19, not trying to downplay it, but you have to be octopussy, putting your hands on all so that nothing is missed out. Let us in on this, Dr. Ngani. What's your take listening to Professor Moosa?
Well, Sulaiman, I'm in a bit of a difficult position, finding myself in a place where I do have to strongly disagree with my senior, not in terms of what he has said the advisory committee in SA has done, but in terms of how serious COVID is. And what I've understood is that the differences in the respective countries, South Africa in particular has a very robust health system. It's leading the world right now in epidemiology. Actually, South Africa has a tradition of uniquely good healthcare. For many, many years, Kenya as a country was referring patients to SA. I also acknowledge what has been said, and I think is perfectly right, that is completely useless to be screening for temperature. I think that is not a useful thing. And I acknowledge that perhaps even the measures that the Advisory Council has presented, there's reason to go that direction. And I will trust the South African government and South African doctors in this. But what I disagree with fundamentally, and I think it's misleading, is to say that COVID-19 is like any other disease. And I wouldn't say that at all. I have been an ICU doctor for more than 10 years now, 11 years, and I have never seen anything like COVID-19. I have had TBs, I've had malarias, I've had, at the point of death, that's what I've dealt with all my life. Critical illnesses in the setting of HIV and AIDS. I've dealt with all those things that I hear every other time doctors talking about. These things have been dealt with us for a long time. And I'm telling you, only one disease in my history has made me doubt my value as a doctor, and that is critical COVID-19. Yes, most people, more than 93%, will have mild or asymptomatic disease, but for the 7% who are fighting for their lives, it's a ridiculous, dangerous thing to make us think that COVID-19 is comparable to the others. It is not in my experience. And Sulaiman, in the respective waves, I have basically lived in the ICU, and I can tell you, I have seen saddening things to the point where if anybody understates the severity of COVID-19, they have missed the point by a mile. And I do invite any healthcare worker from across Africa that if ever we got into another wave, and I hope we'll not get to that point, that is quite severe, we can go ahead and share, just be with us for a short while. And I think just 2-3 days in that ICU will make you change your mind. Other than this, I want us to just be a little bit more careful as well, because in Kenya, we're not seeing as much Omicron as we are seeing the Delta wave. Only so far, I think just over 30 cases have been confirmed so far, out of over 5,000 cases in the last few days, meaning that the current wave remains a Delta wave predominantly. The symptoms are definitely different. We are seeing a lot more of fatigue, a lot more of joint aches, pains. Previously, we were talking about running nose not being a very key thing. This is now seen, and there's this view that the symptoms are much closer to what you'd call a flu. But then the flus have never been this serious, and in fact, every single case that you're testing, you're finding that COVID-19 is pretty much out there. What worries me is that we've known for a long time that what sends patients to ICU is not the initial viral wave where you are getting all these symptoms, but later on when your body begins to respond to this by what is called a cytokine storm. So it's not the initial infection that makes you require ICU care, but in fact, it is the later situation where your body begins to release all these markers of inflammation to sort of fight off the infection. And I'm worried that in the next 2 weeks, we probably need to see the direction it's going to take and see if that's going to have an impact. I must say that Kenya as a country has done pretty well. We have had over 9 million vaccinations. About 3-point-something million has been vaccinated fully, about 13% of the population. Of course, it's much, much lower, but most of these people reside in the capital city of Nairobi, which is where the infections have been most rampant. And we are seeing a lot of infection across affecting healthcare workers, but most of these healthcare workers have been double vaccinated. And perhaps this explains why it's not as bad in this season. However, I would be very hesitant to imagine that there's something unique that's protecting us other than possible environmental factors that influence the spread of COVID-19. If you remember, Africa is one of the few continents with very low average populations. I'm looking at countries like Uganda, where more than 50% of the population is below the age of 20. Average age of 14 years in some countries compared to 48 in a country like Japan, for example. And these differences do favor us to some degree, but let us not be mistaken. We have seen COVID-19 kill in Africa, and that means we are not safe. Let us be cautious.
Well, Dr. Akase, I know you want to weigh in on this, and quickly let me also throw this before you react, and it has to do with how people are taking COVID-19 specifically in Lagos. Let us in on the believability, especially of Lagosians and some Nigerians, and tell us more about the testing of COVID-19, specifically in South Africa. We understand that the government has done enough to, reduce the PCR test, but talking about the fee, but in Nigeria it's still very much expensive for some. Let us in on what the government is doing, Dr. Akase.
Thank you very much, Sulaiman, and thank you to my colleague for that robust conversation on this. So to start with your question, in the country, and to be honest, a lot in Nigeria, for example, and Lagos State specifically, it's better than the feelers I'm getting, in other parts of the country. But even then, in Lagos State, like I mentioned earlier on, there's a lot of under-testing going on. We're not doing enough testing. So it's difficult to tell to do genomic sequencing or mapping or where exactly are the drivers, of this. And because of whether that's a consequence or a cause of this, the attitude to many people in town has been now. We know that to a large extent, people in Lagos, for example, have because of a lot of factors, are rather reactionary when it comes to COVID. Now that we're seeing some of the numbers we're seeing, people are sort of, these numbers are there, so what do we do now? But before now, to a large extent, people felt like, we're tired of hearing about COVID. So most people were not paying attention to some of those basic things in terms of, limiting community spread, and cutting all of that. And that, translated across, various people. So really, that was a major driver or hindrance to, mapping and, putting the proper structure in place, in terms of that. Now, concerning how this impacts on the approach to healthcare workers, and that Prof. Moosa has mentioned, in Nigeria, from last wave, from the third wave into the fourth wave, as a country, the policy had been to decentralize COVID care, so that people with mild to moderate care can be provided even at primary healthcare level, even on a virtual basis, or some local primary healthcare doctor, attending to people that have COVID. However, my colleague from Kenya had mentioned, to be honest, some of the infrastructure at a primary and secondary healthcare level leaves a lot to be desired. So, for example, if a healthcare worker working at whatever level of care, mainly primary and secondary, have come out to say that, I don't feel comfortable providing this care for this patient because I don't feel that, some of the infrastructure I need to be in place is there for me to provide this level of care, which I should be able to, but because I don't feel comfortable with the infrastructure around, I am not going to provide that care. Because everybody knows that there's deficit in the kind of infrastructure that should be available, people like that, cannot be, questioned more or less. So if somebody comes out and says, based on infrastructure around me, I'm not comfortable providing this kind of care, let them go to where, they can be provided for. There's nobody to question them because everybody knows there's a gap and a deficit in terms of training and infrastructure. So on paper, in the country and in Lagos State, and to a large extent, people are doing this, provide care for the mild to moderate COVID. But when it's severe or critical, like a colleague has said, of course, definitely they need to go to where they can receive the kind of specialized care. And I think that's what Professor Moosa was saying, the kind of specialized care. However, where the difference coming is at primary health care level, is every facility, primary or secondary care, with every facility confident enough or willing to say, oh, I'm going to provide the care that I can provide, whether they have COVID or not. When they say I cannot do it, you can't, nobody comes out too strongly because everybody knows that a gap which, should be addressed and taken care of. So I think the models, and the difference we're seeing, in those two models probably are driven by, some of the kind of infrastructure. For example, our primary health care facilities that are providing COVID care, you don't hear, of them saying, I'm not going to provide care because of this. Because, in the primary facilities, they sort of putting infrastructure in place for them to cater for, the kind of care they want to provide. But when it comes to public health facilities, that's where a lot of, in the country and in Lagos State, for example, this is a major issue. Because, like I said, if you couple that with a lot of gaps in terms of the way the community has approached it, and this has nothing to do with lockdowns or anything. For example, if you go to our marketplaces, if you go to where people are gathering, there's practically no protocol in place. You see people basically just moving around and a lot of community transmission going on. And that we've recorded 500% increase in number of cases is still, in my estimation, a gross underrepresentation of what's really going on out there in the community. So to be honest, what the community transmission in Lagos State and elsewhere in the country is going on uncontrolled and unmitigated. And this, I think, is when you put in the sheer numbers involved, is where the danger. And if you couple that with the fact that the clear implementation of policy is not trickling down to all levels strata of healthcare, it just means that there's a lot of work that needs to be done, even in this first wave, even though we're saying that majority of cases are mild. So that is really where the issue comes in for us.
Okay, let me bring you Professor Moosa quickly here. Professor Moosa, we've had 4 variants now from 4 continents. Is there a possibility that we keep seeing new variants, new waves?
Absolutely. I can't imagine that there wouldn't be. We've got variants on influenza every year. And so the likelihood is that COVID is going to go in that direction. I think, the risk, of course, and I think this is the worry we have, is that instead of becoming less virulent, or less, perhaps with less severe disease as Omicron has become, I think we need to be aware that it could actually become more, severe disease that comes with a new variant. So I think we can never keep our guard down, but we must be appropriate in our responses. And I think that treating, the COVID presence as a new normal, I think is very important. And we should be careful. I can understand my Kenyan colleague and fear of seeing patients who just simply die on you in an ICU. But we've got to look at the numbers, there are lots of other patients who die miserable deaths in ICUs and one has no power to do something. And I think that's perhaps the bigger challenge, is that, the current response in some ways is driven by hospitalists who are looking at, their powerlessness in that space. And we've got to look at a society as a whole and say, how do we deal with this epidemiologically? How do we deal with it for everybody? Yes, we know it has serious consequences. If you do get it in severe, you land in ICU, it's pretty miserable state that you might have to die in. We know that. But we've got to look at our country as a whole. And to me, that's what we have to look at. What are the numbers like? How do we prevent this? How do we educate our community? And to me, the key message is to make a much more appropriate prevention plan, things that do not disrupt people's lives so completely. And lockdown is messing around with people's livelihood, and we've got to acknowledge that. Uganda, at one point, they stopped a doctor from traveling to the clinic. Where's the sense in that? That's the kind of absurdity going on in African governments. So I would say, yes, we need to have freedom of movement. We need economic livelihoods to continue, but we do need to tell things that we know by so far that do work, and we need to make sure that the rubbish gets thrown out. That, masks are good, that distancing is good, and that people need to be aware of it and think about it in all of the places. And sanitizing is, yes, useful, but it's not the only solution. This is now more a air transmitted than droplet. So I think that this needs to be made to people clear that, listen, this needs to be spacing much more. We need to be making people aware of it. And yes, in some ways, creating rules. Yes, I think the vaccination is great. You know, its effectiveness is definitely there. We need to encourage it. And we need to make sure that this misinformation is dealt with. And I think we have the space. If Omicron is the bigger dominant virus across Africa, we hope it doesn't spread because it's far quicker spreading. But I think then the other thing is to see exactly what's been said. If we have to deal with this disease, it is not by building more hospitals to deal with just that serious patient. It's about building the primary healthcare system to make sure that we have this, not only manage COVID at a lower level, but actually manage all diseases and have a balanced approach. And, you know, I might be seen as, making the COVID pandemic look less threatening than it is. But I think we need to look at it big picture and actually see that we need to make people healthy overall. And that includes their livelihoods.
That's a fine line. We need to make people healthy overall. And I'll come back to you, Dr. Ngani. You know, we've seen cases of a fully vaccinated person getting infected, and even after receiving the booster dose. What does this tell us about the virus? Also, I want your reaction to, information. Is Africa giving its citizens, its people, enough information about COVID, about vaccination?
Well, Sulaiman, I'll start with that one. For sure, we are not. We can never have enough information. We could ramp it up, and there's a big disparity in terms of the information being given across the countries. And of course, it goes hand in hand with how severe COVID has been in that country. You can see there are countries that have had serious waves and numbers. There are countries that are yet to really witness COVID in its real form. And therefore, in those, based on your experience, people would have different views around COVID-19 and perhaps attach, can I say, different levels of prominence to the information that is being shared. But certainly, there is room to escalate and improve on the information that is being given. One, the accuracy to the content of it, and also just to pay attention to the purpose of this message, even as it's being delivered. Now, I want to agree, Professor, on something that the whole thing here is to prevent, and prevention is always better than cure by a mile. I mean, that is beyond debatable at this time. But look, the reason why COVID is an issue is not for the asymptomatic cases. It's not that it's affecting people, infecting people. In fact, COVID infecting is not an issue if it's not risking your life. And the only reason why COVID remains a concern as it is for the severe and the critical illnesses, as well as now the long COVID. If it weren't for this, if COVID was just all we are seeing now around the Omicron wave, maybe I would just say Omicron plus vaccination that's making the infections mild, it would be a non-issue and no more than the flu. But in fact, it's for this subset of patients that are dying that makes life very difficult. And I just want to share clearly that minus COVID-19, our ICUs had pretty good outcomes. 85% survival. I mean, that's slightly better than the world average of over almost 78%. And the Western world, even with COVID, there are many centers where they're implementing things like, taking your blood out and giving you oxygen through some machines, and people go home. And if it's good enough for the European, why is it not good enough for the African? And to say that because it's one person who's critically ill, then it's okay for that person to die. No, it's not okay. Not if you are in my line of work where you are able to do something and we do have some successes, just that the numbers are so low in terms of those who have been intubated that it's difficult to, compare that to the non-COVID era. And so I opt not to give up on my patients because I know there are things we can learn, and as we've improved our competence around managing these cases, you're seeing better and better outcomes. And mind you, in countries like Kenya, we have seen the COVID situation improve the standard of healthcare because we've been forced to learn new things and to create capacity and to invest in equipment and to look more critically at these patients. Across board, we are seeing improvements in care, but not to take away anything from the need for prevention, which remains primary. I think all of us are focused on this particular agenda, and it's not a fear-driven issue. It's an issue that is driven by the reality. And the reality is that if you're not quick enough, we will have surges that overwhelm health systems. Look, One of the reasons why countries like Italy that had fantastic health systems broke down is because they had too many patients requiring ICU at the same time. The reason why India had the issues it had beyond its inequalities was that they had massive surges. And it falls on us to learn from the experience of those who've gone before us, to understand that the real issue is to ensure that these infections come in manageable rates. There has been a wave in Kenya where people died for lack of oxygen. Lack of oxygen. It wasn't very severe, it's just that oxygen was not there because the numbers were too high. And the same thing, if we learn from the West, if we learn from other African countries, from the previous waves in our own countries, we understand why it's important to ensure that we limit the spread in society to what is manageable. Again, if we can limit the mortalities, if we can limit the morbidities from COVID-19, then we make it less significant. And that's what we are working towards. And I would encourage all of us to join forces to make sure this is addressed appropriately.
Let me bring in Dr. Akase here. Dr. Akase, recall, I'm very, very sure, certain, growing up for you just like me, will recall so many slogans by the government to the extent that till this day, we still can remember them. Is the government or agencies like the NOA doing enough to help your work?
Okay, yeah, that's a very, very, in fact, it's one of the most important concepts that needs to be driven now in terms of, driving the conversation beyond, and I think this is very, very important to drive the conversation beyond just, what we see in hospitals. I get it that, those of us who work in hospitals that, refer COVID patients do see dramatic presentations. And most times I have a scenario where the moment I step out of the COVID ward and step, even within the hospital, you see that sharp disconnect between what you see inside and what is the perception is. Even within the hospital, some staff within the hospital, talk less of those who are outside the gate. There's that sharp disconnect between what you see, and what the people perceive. And, this boils down to the fact that, somehow the messaging, the kind of messaging that is appropriate so that it doesn't unnecessarily create panic. Because to be honest, I think the initial messaging that we sent out was that, COVID is terrible, it can kill lots of people and so on and so forth. But the people on the street didn't see people dying or falling down on the street. So that disconnect between, so all this noise for what? I mean, it's no big deal again. So that disconnect between what we perceive as, what COVID can do in its severest form and how we can communicate this to people, in the street has been something that I feel, and, I agree with you. Somehow, the NOA, and I may not be able to say exactly what they are doing, but somehow I feel that there's still a lot of work to be done in communicating this, correctly to people, to understand. Now, people who work in infectious diseases, the clinical infectious diseases, face, some dilemma. COVID, as we know, is a respiratory pathogen that is, airborne now, and we're seeing changes in the way it's behaving, so much so that the risk perception, to be honest, on a global level, has been downplayed a little in terms of what the full risk is, in terms of the whole community, as a whole. Unfortunately, and so the infrastructure around most infectious disease facilities now have been tailored towards COVID, that. Unfortunately, for us in the country, we're still dealing with episodes of other infectious diseases that are driven by another model entirely. For example, 2 weeks ago, we lost 2 colleagues to Lassa fever. There were surgeons who were operating on someone, contracted Lassa fever, and died. Earlier today, someone called me about a pregnant woman that had Lassa and to come. And so, and the reality on ground, however, is that most of the facilities that have infectious disease facilities have downgraded, risk perception in the light of COVID. So, even though both of them are infectious diseases that are caused by viruses, the transmission modalities are different. Lassa fever, the way you handle Lassa fever,
sorry to butt in here. Isn't that what Professor Moosa was trying to explain to us a while ago?
Yes, and that is, that's exactly what was said. However, the dilemma in certain healthcare settings is that infectious diseases are not all, you cannot blanket all of them. So, for example, now a lot of infrastructure has been dedicated to COVID, which is good because that's also facing. But there's a disadvantage in that now, for example, if you tailor your approach in terms of infectious disease and approach infectious disease to COVID, which now is respiratory, it's a respiratory pathogen. You don't need so much of infection prevention control level of risk perception to attend to it. So we're discussing now that yes, we can downgrade COVID care to the primary healthcare level, build primary healthcare level to be able to handle COVID. But Lassa fever is a bigger risk, to primary healthcare. You can't handle it like that. If that breaks into a primary healthcare and they handle it the way they handle the COVID case, and it's going to be catastrophic. It will wipe out, large number of people as well as a few others. So, and it now boils down to the fact that, healthcare systems, and you were saying this, COVID met some of our, country's healthcare systems in a bad state. Now, the pressure in terms of being robust enough, for example, for example, we have an infectious disease hospital whose capacities and capabilities have been tailored towards COVID now in terms of respiratory pathogen, how they're attached to that. Now they have multi-drug resistant tuberculosis, which is also respiratory, but it's, aerosol driven, that requires admission. You can put them together. Then, of course, you have Lassa fever, which is blood-borne primarily and contact-driven. You can handle that together. The personnel has to be different. The structures and approach have to be different. So, on one hand, the healthcare system needs to be robust enough to both appreciate that in the sense of COVID, we're downgrading the general risk perception and communicating it appropriately. But we have to do this in a setting of other more, dangerous pathogens, which are also present in the field that we have cholera, for example, different pathways. So healthcare systems must be resilient, and unfortunately, while we are communicating these things, people, tend to hear something that is louder in the particular. So now we have a situation where, like I said, Lassa fever broke into a particular hospital, a patient died, 2 senior consultants died, another doctor got infected before somebody, began to suspect that, we may be dealing with something sinister here. Unfortunately, it's probably down to the fact that, the communication was not enough for them to, on one hand, you should be alert to some of the dangers that are coming. On the other hand, you can handle this in a way that, doesn't necessarily, raise. So the balance of both communicating the right way, both to healthcare workers and to the public, while maintaining a sense of alert that responds appropriately to both high risk and low risk, is a delicate one. And our healthcare systems that were struggling before now are really, really finding it difficult to cope with all of this. And I think, going back to your question, the communication has to be in such a way that, people appreciate the risk without necessarily, paralyzing our society, for moving on. Because everybody knows COVID is not going anywhere.
Dr. Akase, let me come in here quickly, and it has to do with the super spreaders. Professor Moosa, help us here because we're winding down. Let's start talking about what may happen. We are in the Yuletide, and definitely this may spread. According to Dr. Akase, he earlier said, well, the figures coming out of Nigeria may be downplayed or maybe underestimated. But what do you think people should do now? First, you've already told us that it's airborne, people should not cluster. Apart from that, what more can you tell the people watching?
I think my simple message to people watching would be, do not let your guard drop. I think it's a dangerous disease and you don't want to get it and have it severe. And to me, the key thing is to avoid crowds. You'd need to wear a mask in public, avoid any closed gatherings. I think that to me would be something you just need to get everybody out into the open as much as you can and, distance from each other. But I think that is still at risk. So if you are a person who is having any sort of comorbidities, any illnesses, or at risk in any way with even obesity, I would strongly advise you to avoid that. I know it's not the best time to tell you that, but it would be the way to do things. I think even any crowded situation, to me, is putting yourself at risk. I do think that life needs to go on. Yes, you need to go shop, but find ways to shop in a way that isn't crowded. I think hand sanitizing is definitely worthwhile, I think, just as a caution. But I think the bigger concern is to keep your what you breathe in and out as secure as possible, and protect others as well at the same time. So I think that's to me the best advice we can give anyone. I think governments clamping down on movement, I think it becomes very clumsy. We do need, and I just want to say, governments are doing nowhere near what they would do in an election. Then they're all guns out because they're saying, vote me and I want to earn money from you. But is that evident in the kind of things that are happening in Africa? Is that the way in which we are doing campaigning out there? It's not anywhere near it. So governments are really slow off the mark. And I think they need to do this. And this is the time when people are most at risk that we should be spreading this message. I don't see any politicians taking off Yuletide.
Before I go to Kenya, I want to stay with you a bit, Professor Moosa. What do these constant waves mean to health workers, their psychology and motivation? It looks to me it can be really draining, isn't it?
Very much. I think that we do need to prioritize healthcare workers for vaccination, ensure that we really address those doubters, and ensure everyone's done even boosters where possible and gets this every year. It's going to be a phenomenon every year. It's certainly been seen in South Africa as very protective, and I think that's a priority in any African country. I think apart from that, we just need to capacitate people. I think there's a lot of nonsense flowing down still from government departments, using outdated questionnaires to screen people at the gates. I mean, I see it in South Africa in my own clinic. They're still doing things that should be thrown out, like, needing to, aerosolize or, spray areas of work. These are completely unnecessary. And it's only a few days ago that a South African government put out something that's a lot more credible. But I mean, this is the kind of thing that needs to happen across Africa to assure people, because a lot of fear is more than the real problem. And I think fear itself, if you don't help people to work through it, is just as mentally draining as the threat, as the disease itself. And I think we do need to be careful of, and we need to, show people, listen, this is a severe disease, but, we only have 2.5% of our full population that is getting it at the moment. And of them, 2.5% that die. So let's not get overly alarmist about it. Yes, I understand, that's not a nice way to die. And yes, it's not the same as the flu, but we don't have to pretend, make it somehow look what is going on in the US and Europe. They definitely have a bigger problem. And I think that, like we said, the protection possibly in Africa is our young age, as we've talked about before, of the population. So we may be feeling more protected, but I think Africa is not in a space to indulge like the US, UK, etc. are doing in terms of their sort of heavy-handed approach. And we don't have the capabilities, and we need to, match what we need to do for our full population based on what we have and to the best we can. And to me, that is starting with using this opportunity to capacitate primary health care. If I may just finish with just saying, in a primary health care setting like we have in South Africa, well capacitated that it is, a pulse oximeter is not even available in a clinic, in a community health center, which is literally having about 300-400 workers, not a single pulse oximeter sitting and available. Now, to me, don't waste your time with a hospital that's sitting empty like we have in Africa, in South Africa, where there's a big, a fully fitted ICU hospital, 500 bed, out somewhere where it's not very useful, when a clinic doesn't have a pulse oximeter, and where the healthcare workers are so confused by the information coming from government that they stop doing pap smears, where our pap smear rate has gone from 60% to 20% because of just very, very paranoid thinking. The same with the HIV care. Suddenly patients are being sent home, said, no, we'll deliver you at home, and there's no sort of monitoring of this patient. And this all is going to accumulate and become a bigger burden than what is happening in hospitals. So I think we just need to be more measured. I'm not saying any otherwise.
All right, thank you, Professor Moosa. Let me quickly go to Dr. Ngani. Dr. Ngani, we're looking at the people now, the messaging that we should be, sending out to the people as they go about, their travels and holidays. Because we've seen cases where some African countries have had to restrict people. What should we be telling people who are about, making that trip for the Christmas and New Year?
Well, I think for that, Professor Moosa is 100% right, and up to the point where we are saying avoid crowds. I think let's take that message very seriously. Again, I'll just echo something that is reported as well, that the question of government restrictions, how useful are these restrictions? And a lot of work needs to go into that to understand whether those restrictions make any sense or have any value. And even where they do, to weigh the two between economic impact and also the health risks. And for sure, there will be some concessions, just to favor lives going on, because this is important. I think in Kenya, very early on, we faced the difficult question of whether to go into the full lockdown, as was happening in the West, and it wasn't possible because the people would be stuck in the house with no food, and therefore that is a bigger risk to them more immediately than the risk of COVID-19. And so in Kenya, we had curfews late on in the night as opposed to a full lockdown. But the question still remains how effective these measures are. Certainly, we're in agreement that temperature screening is probably completely useless. Even some of these forms people are filling, some of the screenings that are being done, you go to an airport, you're all set aside. Once you get to the plane, you're all full in that space. You come off the plane and you go to a mall and a political rally. And the question is whether all these measures are important. And of course, travel restrictions from country to country, I think it's becoming even clearer that these kinds of measures are no longer useful and do not have any impact. And so in terms of the measures being put in place by government from a global space, restricting movement, those measures have to be reevaluated, one for impact, and secondly, to seeing how they disrupt life. However, even as governments relax some of the measures, even as they take away some of the restrictions, that responsibility is transferred from a national scale to an individual scale, where all of us are called upon to understand that COVID is still here with us. And as a result, the prevention measures, these are measures you have to take individually. There is no point going home for Christmas to celebrate and say, I can't live without my parent. And then you infect them with COVID-19 and they die. And now you will not live without them in December 25th. You live without them for the rest of the next 15, 20 years. And that's exactly what's been happening. And the other message I want us to understand, because even in Kenya today, there are those who do not believe that COVID exists. There are those who are waiting to be affected personally to understand that it's serious. And we are seeing these conversions every single day. Families come in and say, Daktari, we did not believe it's this severe. Now we understand, now we believe. And the believers are becoming more and more, because this is not a scheme from the West. No, it is not. This is a reality that's affecting us.
All right, let me bring in, apologies, let me quickly bring in Dr. Akase for his closing message to Africans watching.
Thank you very much, Sulaiman. Yeah, so I agree with my colleagues that the messaging has to be consistent, avoiding like.
Well, it looks like there is a glitch on that connection to Dr. Akase, but it's a fine time for us all here. In the spirit of the Yuletide, all three experts have said, protect yourself, your loved ones, and as various countries have asked, it's time to beware of the wave and celebrate responsibly. Many thanks for being such nice company, Professor Shabir Moosa, Dr. Victor Ngani, and Dr. Lorhen Akase. Many thanks, and I'll see you again. I'm Sulaiman. Bye-bye.